Hi, we're back. So I kind of tend to yell when I'm on these things, so I'll try not to. Hi, everybody. We're talking to Dr. Mark Chiefin at NYU Lego. He's has been observing some interesting things and learning about this disease, which I think might be super valuable for you all. Let's see if he's on this, asking to join. I've got some of my good friends who follow me on Instagram pretty regularly. I hope you guys are doing okay. I think that this quarantine period is going to be a lot longer than we thought. And while we're waiting for Mark, do you guys have any questions for me? Any things you want to tell me? Please keep it clean, people. Don't be a hater. Let me see. We've got 48 people joining. Hi, everybody. I hope everyone's doing okay. I'm busy writing my book. I'm trying to be positive too. Someone says it's hard to be positive during this time, but I hope you all are doing okay. Oh, here it is. Here's Mark. I think if we have enough food to eat, and so many people are really, really suffering right now. And there's Mark. Hey, Mark.
Hey, hi, Katie.
Hi.
Here's Renee. We're going to socially distance and take our masks off so we can talk to you.
Oh, excellent. Thank you so much.
Hello, how are you? I'll go.
Yeah. Hey, Katie.
I just introduced you to my followers. Gosh, your hair has gotten very gray, Mark.
Yeah, I know. I think it's all this COVID. You know what? I think it's the lighting, Katie.
I was explaining to everybody earlier that you took care of Jay when he was diagnosed, and as a result, we have become very, very good friends. I think we're bonded by something that few people, I hope, ever experience. But one of the most positive things that came from Jay's illness was the fact that I met you, Mark.
That's sweet, Katie.
And I'm getting off the verklempt
saying that. Jay was such an incredible person, and it's so tragic. And what you did in his memory and how many lives you saved, more lives than any doctor could ever have saved from colorectal cancer and screening. So thank you for that. But Jay was special, and it's still, like yesterday, just a terrible, tragic loss. I'm sorry, Katie.
Well, thank you. I'm sorry. I didn't mean to start on that note. And Ellie's watching. Ellie, my daughter, is watching. I don't think Carrie is. Carrie's busy cooking dinner. She's become quite the chef. But Mark, on to more important things, and that is what you all have been dealing with. First of all, our humble and profound thanks for putting yourself in harm's way and for doing so much for so many people, Mark. You and I always have these interesting conversations because I think in another life I would have become a doctor if I wasn't so freaked out by the sight of blood.
You know a lot, that's for sure.
And, but let's talk about some of the things you're seeing at NYU Langone treating these COVID-19 patients. You told me that there's no medical literature, and you're really, I hate to say you're shooting from the hip, because nobody wants to hear about a doctor shooting from the hip. That's like that Geico commercial where the doctor comes and says, "I just got my license back. I hope I can do a good job," or whatever. But talk to me about, on a serious note. I don't need to be have too much levity when talking about this, but tell me about some of the things you're seeing, Mark.
Right. So, Katie, it's unprecedented in modern medicine that we're really learning about this virus in real time. And although we're shooting from the hip, we're doing it with a lot of medical knowledge that we have before. So we're using everything we know. We're trying to apply it to this disease. But there are a lot of unique features about this disease that we're seeing. Some people don't even know they had it and are even completely surprised to find out that someone else got it, or that if we test them, that they test positive. And others get so sick, they end up in the hospital, potentially the intensive care unit. And for the very few, it could even be lethal. So it's such a crazy virus like that, from nothing to everything.
And what I've been fascinated, Mark, is how some people get sick and even die from this, and other people have it and they have the antibodies, but they never even knew that. Right. How do you have you been able to figure out why this is impacting some even seemingly healthy people with no pre-existing conditions or comorbidities or whatever, and then how some people, you know, are able to. I mean, who knows? I might have it, right?
All of us could have potentially had it, not known it. Might have been from just a little cough or runny nose, or just something that we didn't even realize we had, to those who are in the hospital. And, you know, the analogy I use is like a bee sting. For some, it's just a little tiny, you know, bump and a little discomfort. And others, it could be an anaphylactic reaction where they could literally get a life-threatening response. So it's our immune system. It's how some people's immune system are geared up to a point where it creates such a response to this virus that it causes damage in the lungs. And that's really where they get in trouble. But it affects every part of the body, Katie. People can get inflammation in the heart. The GI system can be affected. We're seeing blood clots, and blood clots going to the lung called pulmonary emboli. So the whole blood coagulation and anticoagulation system is activated. So people respond differently.
Yeah, and it's sort of crazy that, as you said, some people can exhibit GI symptoms, other people can have migraines, some people, sorry, people tell me to stop touching my face, but I got a little foot clamped and my nose started running, everybody. So I apologize, and I won't touch my face, but I don't want my nose to run in the middle of this. But someone says, way to go, Uncle Mark. Bissy Elliott, is that your niece?
Probably is, yeah. Uncle Mark would be my niece, yeah.
Anyway, it's just so strange that there aren't consistent symptoms among people who are infected.
Yeah, people are different. We do know certain conditions can be worse if they get the virus. And so older patients, obesity seems to be a big factor here.
That's what I've been hearing. A
Have,
lot of the patients are overweight. Sorry to interrupt.
Yeah.
Keep going. Sorry.
No. But the obesity might be related to things like high blood pressure, diabetes is another factor. So it's not that they're more prone to get the virus, but if they get the virus, they may have a worse outcome. And that's why those people in particular need to be so careful and socially distanced.
Oh, that's so interesting. You know, there's a whole conversation to be had about the socioeconomic factors. As we were talking about early, I'm not sick, everybody. I just have my nose was running because I got a little emotional. But we were talking about socioeconomic factors. You told me earlier that you're seeing this among certain populations. For example, anecdotally, we should point out, you're seeing it among several Latinos. You're seeing that it's affecting that population. Can you tell us more about that?
Well, we're just, you know, again, because we're learning this in real time, we're trying to see if different populations are affected in different ways. And in Brooklyn in particular, we're seeing a lot of Hispanic patients actually present. Now, part of it may be the demographic of the neighborhood, but there does seem to be, at least among the chatter nationally, that there may be a higher predisposition. We don't know. You'll speak to Renee Williams, who's working at Bellevue Hospital, and she could talk to you a little bit about the demographics of the patients she's seeing there. But there may very well be a difference, and we're just not sure, but we're looking very closely.
What other things have you noticed? I know you've been working in the hospital for the last 4 days, I think, Mark.
Right.
And I'm sure you're exhausted, by the way, but tell me what other things you've noticed among these patients. Any stories that you can tell us about why this is particularly upsetting for patients and for families, and quite frankly for physicians. And then someone was asking about ACE inhibitors, so you can also talk about that first if you'd like.
Well, we're not exactly sure about the ACE inhibitors. Obviously, they know that the receptor is called the ACE2 receptor. It's in the lining of the lungs, it's in the gastrointestinal tract, the heart, and other places. And people who are on the medications, we're recommending they stay on them. We don't think that there's actually increased risk, but we don't know. Some people say there might be an increased component of the virus getting in because these receptors are upregulated. Others say that maybe it protects. So we don't know. But the good news is...
I'm sorry to interrupt, but what are ACE inhibitors? I should know that. I'm kind of embarrassed.
It's medication for blood pressure, primarily. That's what it's used for.
Okay.
It blocks the receptor, yeah.
But then there's this other thing that in the lung, these particular cells that have a coating that, remember, what are those called?
It's the surfactant. What we worry about is that what keeps the lung, the alveoli, open may be, in fact, affected by all the inflammation in the lung.
Oops.
And what we're seeing, though, is the isolation of patients. And that's the part that's so difficult, because patients have to be isolated, obviously, from their family. And when we see them, we're like in armor. I mean, we're, in our PPE, and we keep our distance. So patients are removed. And Renee has a really a heartwarming story about how she held a patient's hand, because they're really isolated from all of their supports. And the compassion, Katie, particularly the nurses, they are the absolute angels of healthcare, but others as well, the transport people cleaning the rooms, they are so kind. The amount of human kindness and goodness that's coming out has been incredible, because people realize how alone, how isolating this could be for the patients. We do everything to keep them connected.
You're freezing just That's so wonderful. And I want to talk to Renee in a moment, but some people are asking about some of the highly select. A friend of mine has just joined us. Can you tell me a little bit about the treatments, the hydroxychloroquine and the other drug with the R, and some of the other things that you're trying on patients? Are they working, Mark?
Right. So we don't know. We're hoping that they're working. I mean, again, we need to study them. This is why it's so important to have trials, so we can compare, because we won't know, because some patients may get better whether you gave them that drug or not. We're using hydroxychloroquine, which is Plaquenil. We're using azithromycin, which is the antibiotic that was reported to work with it. And then we're using zinc. That one people don't realize, that the hydroxychloroquine allows the zinc to get in and potentially be effective. So we're hoping it works, and we're getting studies going. And then there are a bunch of other clinical trials looking at things like the IL-6 receptor, blocking the IL-6 receptor. These antivirals, like you're discussing, which are been used in HIV type treatment, are now being applied to this COVID-19. So we have a lot of things that we're looking at, but we don't really know what works and what doesn't. And we're trying to pick the ones that we think have the best efficacy, looking quickly, and then trying to use the next best treatment for patients.
I know you and I were talking about vitamin D, and someone was
Yeah.
asking if vitamin D helps. Mark and I had a long conversation about vitamin D earlier today.
Yeah, I'm a big fan of vitamin D because it might prevent colon cancer as well. So to be honest, I've been taking vitamin D. That's one of those low risk interventions that I think won't hurt.
Yeah. By the way, I'm talking to Dr. Mark Chapin. Hey, Doc. Mark, you have this big fancy title now at NYU. What is your title?
Well, I'm the Vice Chair for Clinical Affairs for the Department of Medicine. I'm also the Division Director for Gastroenterology and Hepatology.
And Mark was basically, I did an earlier interview with him, which you'll see that Time and I are collaborating on. But Mark was really responsible for getting all these doctors from all sorts of disciplines to kind of get together, from plastic surgeons to ophthalmologists, to all these doctors who are in these subspecialties, to come and join forces at NYU Langone, right?
Katie, it was so moving and so inspirational to see everybody come forward, really step up. I sent out an email to all the department chairs with my surgical colleague, and within an hour, we had literally hundreds of emails coming back saying, how can I help? What can we do? And basically, we created what we call a COVID army, literally an army of reservists. We have supplemental doctors who aren't primarily medical doctors, working with the medical doctors side by side with their colleagues. And then we have people like myself, trained in internal medicine, but doing some specialties, going back to our medicine roots and running medical services with interns and residents. It's been incredible. The collegiality and the enthusiasm to help our patients has been really, above all else, just something that has motivated all of us to do more.
I know that, people asked how much, Ellie just said he's the best. How much vitamin D should people take?
Just 1,000 milligrams. Yeah, 1,000 units, excuse me.
What about vitamin C, Mark? Is that advisable as well?
You know what? There's been no data really for that at all, but some people take it for colds, but I don't think there's any benefit there.
Okay, I have to ask you this because, everyone gets excited when we have a doctor on the line, so they ask all these questions. They were asking about zinc. Should people take zinc prophylactically?
It probably will not work. The reason we use zinc in the hospitals, we're using hydroxychloroquine, and that's probably activating and allowing the zinc to get in and work. So some people were recommending zinc like for colds. Whether that works or not, we just don't know. But I would not recommend it.
And what about, wait, I had something else to ask you, and then someone asked me a question and I lost my train of thought. Any other supplements or things that you think are advantageous?
I think it's keeping the immune system healthy, so getting plenty of sleep, which is not easy with all the stress. Getting outside is important. We want to keep our distance, but we do want to exercise, taking a long walk, getting fresh air, keeping your body moving. These things are very important to help really keep the immune system at its best.
Someone said D2 or D3.
Oh, I would
D3.
say, yeah, I would say it's best just to take either a multivitamin. I wouldn't get too specific. It's usually better just to take a multivitamin with vitamin D in it.
And before I talk to Renee, a lot of people are still asking, and I wonder if you've seen any more literature about Advil versus Tylenol, or a lot of people are asking about that.
Yeah.
You know, there was some scary stuff going around. Sorry, I just touched my face. Do you know you touch your face between 2,000 and 3,000 times a day? I learned that when I watched Contagion the other day.
Katie,
I don't
if you
recommend.
see my hands, I literally take my hands and I keep them in my lap like this so I don't do it, or when I wear a mask. But I really consciously try and keep my hands from my face. Your viewers could tell you whether, I don't know whether I've touched my face during this interview.
No, you're doing really well. You're doing really well. But what about the Advil thing?
Yeah, so we don't think that there's much to that. If there's a choice and it doesn't matter, we're going with Tylenol. But people take Advil, we're not too concerned about it.
Really? And
Yeah.
and okay, so people shouldn't stress out. But overall, just keep yourself healthy. And I know Renee's going to tell us some. Oh, wait, before you go, and then I'm going to go to Renee because I know you guys have a hard out at 5, Mark. But I must be tired or stressed out, and I bite my nails too. I wanted to talk to you about meeting with your fellows. You have some very, very young doctors that you're talking to once a week, even before this pandemic. And now you've been talking to them virtually more often, every day, maybe?
Yeah.
How are they doing? Talk about baptism by fire. I can't imagine being 20. How old are the youngest doctors, Mark?
Yeah, they're in their late 20s generally.
So being Ellie's age and having to deal with this, how are they doing?
So the stress factor is really present. I think being there and feeling like you're doing something is very therapeutic, but there's an anxiety that we all have. I think we all know that PPE works, but we have to be very mindful of the PPE. And Renee is actually our fellowship program director. They all report to her, so she checks in with them very frequently. I check in with my faculty and the fellows, and every Friday I've always met with the fellows. And this morning I met with them, and they're in the intensive care units helping on the front lines. They're on the floors. They're working at nights. And they all did it voluntarily, Katie, because they're trainees. Now, they're all board certified internists because they're doing their subspecialty in gastroenterology, but they came to learn gastroenterology and they're in the front lines fighting COVID. That's really the ethos of the profession, is this ability to try and give back to people and really put others, the care of others, ahead of all else, particularly in this pandemic, this crisis.
I hope there's some kind of counseling or psychological support for all of you, because I can't imagine. I think I would just be crushed to see so many people succumb to this, and to be alone and to not have a family member with them. I don't know if I could handle that. Do you have people who are helping them, giving them psychological support?
Yes. In fact, we just had our grand rounds by a psychologist for the entire division. We've had the fellows meet with someone to help. We do relaxation with the division. We actually put on earphones and at night go through the mind-body relaxation, kind of muscle by muscle, joint by joint. And there's tremendous availability to all of our house staff and to all of our physicians. It's critical, Katie, you're right. The level of stress and anxiety is really at a level that if we don't address it, it's going to make us sick as well. So I'm glad you recognize that. And fortunately, so do healthcare professionals. professionals, and we speak very freely with each other. I also, as you know, I'm president of the American College of Gastroenterology, and our
I
board
know.
meets we meet every month just to talk. And also, New York being the epicenter, we're trying to teach the rest of the country what we're going through, trying to get them to prepare so they're ready for this kind of tsunami of COVID disease.
And, I read earlier that probably this shelter in place order is going to extend into May. Have you
Yeah.
been hearing that as well? Sorry, I just scratched my face. Have you been
Yeah.
hearing that, Mark?
We're not sure. It could be. What we're seeing, Katie, is a leveling off, and that's actually very encouraging to all these wonderful people who are watching. Thank you. If you've been staying at home, keeping your distance, watching your hand, it is working. In fact, what you're doing is even more important, saving more lives than any physician anywhere in the field. I can't stress that enough, because we're seeing a leveling. And Katie, the projections were so miserable a few weeks ago, and we're seeing it less than what we expected. So we're so hopeful. And that might mean that actually, although we may need to stay in place, we might be able to test, see who has antibodies, get people back to work. There's all kind of possibilities now. So I'm not sure. It could go into May, but at least if we start seeing it level and then come off, we could see an end in sight. Everybody says this is a marathon. The problem is it's a marathon without a finish line. We don't know where that finish line is. So it's rough. We have to pace ourselves. But maybe if we see a leveling off, we can have some hope that we're coming to the other side.
But I think restarting life as we knew it is going to have to be done extremely carefully, because we don't want this to then spike again because the virus is being spread. And one last question before I get to Renee, don't kill me, Mark, is a lot of people are saying the test is not very good. The test for COVID-19, there are a lot of false positives, false negatives. A lot of them are not very accurate. So I'm curious, when is there going to be a better test? Because isn't that one of the keys to getting this under control?
Yeah, and there really aren't too many false positives. It's the negatives. And so anybody who has a clinical suspicion, we just assume they have COVID-19. The test is a swab that goes in the back, really.
And as
deep in
you
the
said,
nose.
you told me earlier that people aren't giving the test right unless they're making you cry.
Yeah.
Ugh,
Yeah,
that
you're a
sounds
good
miserable.
listener.
It just made me like,
Yeah, but you know what? We have much better tests coming about. Actually, they're looking for just a regular nasal swab, which you might be able to do on your own and not have someone do it. We're looking for a blood test for antibodies, and these things are right around the corner. So I think testing is going to get much better, Katie, and by doing so, we'll know who had it potentially if they had antibodies and who has it by a more simple test. So fingers crossed.
And Mark, the vaccine, I keep hearing 12 to 18 months. I feel like there's a global effort to make this vaccine come to fruition. Given that, do you think the time frame could be faster than 12 to 18 months?
Well, they're actually already phase 1 trials, and we're about to go into phase 2. Now, the problem is, Katie, that for a vaccine, not only do you need to make sure it protects, but there have been some times historically where vaccines actually augmented or increased the immune response and actually made things worse. So that's the problem. I could tell you that everybody is working as fast as possible, and one of the big vaccine centers actually right here at NYU by Mark Mulligan. And we've been talking a lot to them. So these things are moving quickly, but we have to be careful. The last thing we want to do is make people sick or even get worse from the virus.
Right, have the cure be another problem.
Right.
Mark, you do such a wonderful job. Everyone loves you who's watching. See, I told you guys, he's one of my very favorite doctors on the planet. And Mark, thank you for everything you're doing. Maybe you can come back and we can just do an ask the doctor, and then I don't feel like then I won't dominate the conversation, because so many people have questions and I'd love to be able to answer them. But I want to just quickly talk to Renee. Will you explain what Renee does, and then hand the phone off to her?
Speak to Renee. I lost you there for a minute, but you could speak to Renee for as long as you want. She's on my next meeting, but I'm going to give her a pass to talk to you as long as you need to.
Well, we don't want to keep her from her important work, but I do want to say hi to her and just hear about her experiences. Mark, I love you.
Yeah.
Give my love to everybody and our gratitude.
Katie, thank you for everything you do. and all of your wonderful listeners and people who follow you. Obviously, they're special people because you're a special person. I'm going to put my mask on. She's in the
Thanks,
other
Mark.
room, so we're keeping our.
I'll
Okay,
talk
here
to
you
you
go, kid.
soon. Okay.
All right, Renee, she's all yours.
Hi, Renee.
Good
How
afternoon.
are you?
How are you? I'm good. Just take this off. Oof.
Oh, so nice to see you. Thank you in advance for everything that you've been doing, Renee. What is your job exactly, Renee?
So currently I'm a general gastroenterologist within the Division of Gastroenterology, but I also am the fellowship program director, as Mark mentioned. So when someone wants to be a gastroenterologist, they have to do 3 years of internal medicine training and then an additional 3 years of a fellowship training program. So currently our fellowship has 4 sites, the NYU hospitals, Bellevue where I am, and the VA hospital in Manhattan, and I have 17 fellows. So we do the entire clinical training program and the educational aspect of that too.
So,
So
Renee, how are all these fellows doing? I talked to Mark about it. It must be pretty traumatizing for them.
I think, it's very difficult. It's a very challenging time. I will say this: they have stepped up in such ways that they on their own. So when this all started, we knew that we had to get deployed. So they're here for training for GI, but obviously we need help all over the hospitals. It's all hands on deck. On their own, they made a schedule and they sent it to me saying, I know you guys are busy, so we wanted to take some of the stress out of your day, and we made a schedule to show how many of us can get deployed and help on the floors in the ICU. It brought Mark to tears, and it actually made me choke up. So they have handled this very well, but of course, as expected, there is a lot of stress and anxiety. Hold on. There is a lot of stress and anxiety, and there's a lot of fear, I think, in all physicians. I try my best to keep up with them, and we make sure we stay on top of everything. And luckily, the institution also does mental health. They have resources available for the trainees, which is great. But I think I think they're handling it well. But as in any case, they're all concerned. They have families. Some are married. Some have newborns. But they've really just stepped up and done such an amazing job in just putting themselves out there. They're coming in on their vacations. They're working nights. And they're like, just put me out there because I feel like we need to do something to help. And independently, like I mentioned, they're coming in when they're supposed to be on vacation. So it's been, they've done an amazing job. I'm very proud of them.
Well, thank you for helping them. Thank you for all that you're doing, Renee. If you could speak a little louder, tell Mark to keep his voice down. I think he's
I
holding
know.
his meeting.
Hold on, your voice down. Hold on.
Tell him I said to lower the volume. But
Yeah, he's on. Lower your voice.
Lower my voice?
Yeah, lower your voice. We're trying to do the social distancing.
Hey, Renee,
Uh,
I know you've been working at Bellevue.
mhm.
What kind of patients have you been seeing at Bellevue, which is a different population than NYU?
Yeah, so we're Bellevue Hospital. Historically, we serve the underserved. So our patients.
I'm
Well,
just
we
putting
just
my
lost you.
earphones in. Okay, can you hear me now?
Wait, hold on. I think Mark is on.
Oh God, hang on. Sorry.
Mark is co-opting our Instagram live, Renee. Tell him he got his time.
I know. I think it was the Bluetooth that just happened.
Wait a sec.
Oh, it's the AirPods. It's Bluetooth.
Technical
Okay.
difficulties, ladies.
All right. I
Is that
apologize.
better now?
That's much, much better. So we have a large Hispanic population, Asian American population, and Eastern European, you name it, we have it. African American, African. So our population really is just extremely heterogeneous in terms of what we're seeing.
And are you finding among underserved populations, because of, poverty is a comorbidity, that a lot of people are coming down with this virus? I talked to Robert Reich about it, dividing between, it's become a very divisive class thing where people who don't have access to medical care, who have maybe having problems, are getting this more. Are you finding that?
Well, I think what we're seeing is health disparities that exist in general. obesity, hypertension, diabetes affects certain population more so because of health disparities and access to care. And this virus is now just one thing. So if you have these particular comorbid conditions, which increases your risk of going on a respirator, increase your risk of dying, then you're going to find that this particular population will get more affected in general. So I think, if you're looking at some data that's coming out, you are seeing increased illness and increased morbidity in certain populations. So there, unfortunately, I think prior health disparities are now affecting current health disparities.
Can you tell us, Mark told me you had a moving story. Sorry, I have to cough, but I'm not sick. Hold on, everyone. Sorry, I hope not. That you had a moving story about someone who was by herself and was so frightened. Cough into your arm. You're right. Sorry.
Oh, yeah.
Can you tell us what happened there, Renee?
Yeah, so I think, obviously everyone's fearful and scared, and we're all here doing the best we can do. And I really want to highlight what Mark said. It's not just us, it's the nursing, the environmental services. And I just thought to myself, these patients have to be extremely lonely. Imagine being in the hospital, being sick, and not even being able to hug or touch another person. It just breaks your heart. Yesterday, I was a part of a rapid response team. So what we do is if someone is having breathing difficulties or might have to go on a respirator, we're the team that responds to it. So anyone who starts to not do well clinically, they do an overhead page and we all rush to the bedside. So we had a patient, she's been in the hospital for a couple of days, she has COVID. She essentially wasn't breathing, her oxygen levels were extremely low. And we went in the room and we looked at the situation. She had on, so what we're doing now is we're trying to oxygenate as much as possible and try to bring the level to work. We
just had a frozen situation.
Patients on their belly. Yeah, we turn the patients on their bellies to try and help bring more oxygen to the lungs. So she wasn't responding to our maximum therapy. And at that point, we realized she had to go on a ventilator. And we said to her, we're going to have to put you on a breathing tube. And she kind of said, well, I don't really know about that. And I kind of stepped back for a second and I said, she has to be so scared. She's face down on the bed. She has all these contraptions on her face. We're standing around her dressed in all PPEs. And I said, she just has to be so scared right now. And we're telling her, you need to go on a ventilator. And she can't speak to her family. She can't call her friends. I just thought this poor patient has to be really terrified. And at that point, I kind of bent down, held her hand, and I went really close to her face. And I said, listen, I know this is really difficult. I know it must be hard on you, but if we don't do this, you might die. And I just kind of squeezed her hand at the time. And she said, okay. And I just, I don't know. I just felt like this is a really, for us, it's a big thing, but for them, it has to just be so much more. And just to be in this space, in this very lonely space, and to even have someone touch your hand or hold your hand, it must be extremely challenging. So I just went down.
How is she doing? Do you have any idea?
She ended up getting intubated on a ventilator and she went into the medical ICU. So she's still there. This is the sad part, I think. As we do know, a lot of people will get better, but I think the issues of those that don't, and to see patients, normally a hospital, Bellevue will have maybe 15 to 20 people on ventilators at any point in time. Now we have maybe over 100, and you're just seeing that over and over and over again. And it's terrible. On some level, yes, it does. We're doing everything we can. And as Mark said, we're kind of shooting by the hip and we're praying and hoping and doing everything we possibly can. But, there's still a lot to learn and there's still a lot to do. So I hope she will be okay. Unfortunately, like I said, she ended up on a ventilator. But
let me ask you a question, Renee, Dr. Renee. Renee, your last name is Williams?
Yes? Williams, yes.
So do you see many people come off ventilators? One of our viewers just asked that.
We have definitely taken we've taken a decent amount off, not as many as we would like. Again, like I said, we're still trying to understand this process. So we've definitely extubated patients, but a significant portion do stay on. And in some cases, we're doing compassionate extubations, depending if the family decides to do so, if the patient is not doing very well.
Oh,
So
that's so hard. And these families, it just breaks my heart for them.
it's hard. I mean, one of the things we spoke about amongst ourselves is, we everyone discussed obviously rationing of ventilators. It's one of our worst nightmares. As a physician, we live in a place where we can do everything. If the family says do everything, we can do everything. And the thought of telling someone, I'm sorry, we cannot do this, how do you put a value on a life? That's the question. Like, how do you do that? It doesn't matter if the person is 85 versus 65 versus 45. How do you tell someone's son, or family member, I'm sorry that this person, because we have a limitation on certain things, we can't do this for you. Luckily, with the plateauing, that doesn't seem to be an issue, and hopefully it stays that way. But that was one of the things that we all have struggled with. We just did not want to have to do that. You can't. How do you tell a child? I know you haven't seen your family member in days, but now they're going to, potentially pass away without you there. It's just, it's heartbreaking.
But in terms of running out of ventilators or not having enough ventilators, you haven't had that problem yet.
When we got the initial projections, we thought that would happen. Currently, we've had donations. We've gotten ventilators coming from other places. They've gotten ventilators from upstate New York, so that has helped a lot. So right now, that's not an issue. Again, with the plateauing, it looks like we might not become an issue, but this situation is so fluid. It's really hard to say. But right now, at our hospital, it's not an issue, and we're all praying it stays that way. Everyone who stayed home and who social distancing, thank you so much. That has made a huge difference in this disease process, and hopefully, we can do what we need to do.
I'm so glad so many people are taking it very seriously, because it's the least we can do to protect each other, but also protect you, Dr. Williams, and all the hardworking healthcare workers who are out there. And a friend buried his dad today. Someone was saying I know that a lot of people, I featured somebody on my Instagram account today where the family had to say goodbye on FaceTime. And I know you all are trying to help facilitate that, but a lot of people are coming to the hospital and they don't have like chargers, and so maybe they don't have their iPhone. Most of them probably do. So you all are really trying to make sure that people have the equipment they need to communicate with their loved ones.
So we have gotten donations of chargers, interestingly enough. So one of my colleagues is giving me a bunch of chargers tomorrow. We're bringing it to the nursing stations and we can give it to the patients if they need it. So one thing I will say, we've gotten food, chargers, masks. The human spirit has really come forward in this particular process where people are really giving and giving and giving. And it's really heartwarming. So tomorrow I'm delivering some chargers to some of the nursing wards, and if any patients need it, they can get it.
That's wonderful. And people are saying thank you who are watching this, and they really are incredibly grateful. So I think we're going to let you go. And I wanted to ask you real quickly though about PPE. Is that starting to be solved?
Well, I think we're being very judicious with it. But we obviously are trying to figure out a way to increase what we do have. We have a lot of donations and people are reaching out to hospitals. So do we have enough? No. Do we have enough currently? We do. But I think it's an ever evolving situation. Hopefully we're doing all the right things. We are trying to reuse certain things in an appropriate manner, looking into reprocessing or cleaning if possible. So right now at my hospital, it's not really an issue.
Oops.
They are kind of, I'm sorry.
Sorry, you just froze. You're looking into, hold on.
Yeah.
Go ahead. We just lost you for a second. You froze.
Oh, yeah. I said at my hospital, it's
and
not.
She froze again.
Yeah. You were frozen for a second too.
I think probably you guys, we should let Renee. Hi. Okay, you guys,
Now
I think we're having some technical. Renee, can you hear me? Oh, okay. Can you move a little bit? I think, are you good now? Yeah. Okay, good.
Yes.
Okay. Well, listen, I'm gonna let you go because you have been so generous with your time, Renee, and we're starting to lose. They're saying she's not. Okay, we're starting. You're getting very blurry from my end. But thank you very much for all you're doing, Dr. Renee Williams. We really appreciate. They say we can hear you both, which we appreciate. But I want to let Renee get back to her patients, everybody. So lots of love and gratitude to you, Renee. And tell Mark I said thank you again.
And thank you all, and and you're welcome, and thank you, and thank everyone who's doing what they need to do in social distancing. All right, let me
All
go to
right.
my next meeting. Nice. Thank
Okay.
you.
Bye, Renee. Thank you.
Bye.
Bye, everybody. Talk to you soon.